My name is Dorothy Honeybender, the founder and president of the Africa Respiratory Care Association. Today's webinar is brought to us by the Africa Respiratory Care Association, also known as ACA. Our mission is to reduce the burden of respiratory disease in Africa by strengthening respiratory care workforce and also providing opportunities for professional growth and promoting innovative solutions to improve respiratory care. And this webinar is proudly sponsored by Zopec Medical. Zopec Medical is a company that manufactures the world's smallest uninterrupted power supply batteries, which provides continuum power during patient transport, ensuring that there is uninterrupted care. It also supports early mobility of the patient, enhances physical and respiratory therapy while you transport your patient. It has extended transport time and compatible to all clinical devices. So if you are in a facility or maybe in a part of your world or where your country is located and you have power interruptions in your hospitals or in your facility, there is a power solution, which is Zopec medical batteries. And today we are going to throw more light on this battery as it supports medical care or patient mobility. Now, for more information about this battery, you can contact Zopec on info@zopec.com, or you can reach them on +1 88 468 7108. Or you can also reach the Africa Respiratory Care with your questions on info@africaresp.org, or you can contact +1 470 357 3590. And with Zopec, we say powering critical care mobility with confidence. So today we have a very special person, I must say very special to me, who is going to present all the way from, she's in the United States, but she is a Lebanese, so to say. And I'm going to say a brief bio of her. So her name is Dr. Sumaya Osen. She is currently in the role of respiratory clinical specialist. She is also the founder and CEO of Elite Logical LLC, healthcare consulting. She has her PhD in healthcare management, leadership, and community health. She holds 2 certificates in quality and process improvement and quality and process improvement black belt. She started her respiratory care at the bedside, and after almost 13 years, she began her management journey in different roles and capacity, including neonatal, pediatric, and coordinatorship, and then also adult, neonatal, and pediatric coordinator in the respiratory care field. She was also an adjunct instructor in respiratory care program for over 16 years. She published a research article in Professional Case Management magazine. She contributed to the chapter in Cardiac Surgery, Essential for Critical Care Nursing, 4th edition. She's a speaker at conferences and at webinars. Her journey is centered at employing research to improve the quality and safety of patient care using multidisciplinary systems approaches and process improvement cycle. She also is a member of the Africa Respiratory Care Association, and she also looks forward to enhancing respiratory care not only in Africa, but the world at large. Today, I present Dr. Sumaya Osen to you. Dear audience, our presenter, Dr. Su, your audience. Thank you.
Thank you, Dorothy. Want to thank you so much for the kind words and introduction. And I want to thank everybody who joined us. As Dorothy said, from all over the globe, we are all on different times. So I would say greetings to everyone. And I'm looking forward to listening to your questions as we go through our presentation today. And so the title of this presentation is Taking Steps to Recovery, Mobilizing Patients on Advanced Respiratory Support. We're going to tell you our story and how we started walking patients on advanced respiratory support that it wasn't mobile at the beginning, but we made it mobile. So we're going to tell you a little bit about why it's important to mobilize the patient and then what we did to make it happen. So are you able to see my screen?
Yes, we can.
Okay, thank you. Just trying to go through the slides. So what we're going to discuss today is the background for therapeutic ambulation. Where did it start? When did we start thinking, oh, we really have to start walking our patients when they are sick in the hospital and in the bed? We're going to give a little bit of historical overview. What are the advantages of therapeutic ambulation? Why we want to walk the patient? Wouldn't it be better just to let them sit in the bed? What does it take to have a successful mobility program? It takes a lot of work. It's not as simple as we think, or just get the patient out of the bed and let them walk. And then what does it take to be able to clear a patient to walk? Can every patient walk? And the time that takes to ambulate, it takes a village, as we say. It takes a lot of people, a lot of coordination, a lot of equipment. And then also, I'm going to talk a little bit about the transports, how important it is to have the equipment to transport patients when they are on advanced respiratory support. So, as a little bit of overview, True Mobility started when Schweikert and et al., meaning all his authors that collaborated with him and researchers, started publishing in 2009 about the importance of mobility and how to go about it. But there are many publications about that importance of moving the patient and letting them walk and not just sit in the bed. And then how the ABCDEF bundle came about. We always hear about the ABCDEF bundle in the ICU, but how did it all come about? So Schweikert et al. In 2009, he started talking about the moving patients who are on mechanical ventilation. When the patient has a breathing tube, whether it's going down their mouth, their nose, or sometimes we have a tube that goes directly in the neck to the trachea, tracheostomy. He was saying we need to start moving these patients. And of course, looking at that, people would say, how can we do that? They are on the vent. How can we move them? And why should we move them? Wouldn't be keeping them in a bed a lot better for them? So over time, he was able to show with his research, he and his team, that moving the patient, letting them walk, not just sit in the bed, it improves them physically and mentally. Because when the patients get sick and they cannot do what they used to, they also become depressed. So it affects their mental health in addition to their physical health. When we move them, we decrease the length of stay. And mobility started as sitting the patient at the edge of the bed. So that's how simple and how it first started. So we're not walking them at that time. We're just moving the patient in the bed, letting them sit at the edge of the bed, or moving them to a chair. Before in 1912, so that's almost over 100 years ago. There were a lot of talks about moving patients when they are sick, and it started with James Herrick. And his concentration was on patients who had heart attack, myocardial infarction. And they were thinking if the patient gets a myocardial infarction, then we need to keep them in the bed. They need to rest because the heart is hurt. The heart is not working well, so we need to keep the patient in the bed until the heart heals. And because when they start moving, the heart is going to become stressed out. So let's not move the patient and keep them in the bed. And because of that approach and letting the patient rest, there was a high number of patients who were dying. Just keeping them in the bed and not moving, it didn't help. It didn't get them better. And the percentage was really high. In 1944, so just think from 1912 until 1944, Samuel Louvain was really the one who started pushing for moving the patient. He was questioning, is that true? We're helping the patient to heal when we keep them in the bed after they have a heart attack. And then in 1950, he and his fellow, they started doing research. His fellow is Bernard Lone. They published several studies to prove that moving the patient in the bed from being laying down to sitting at the edge of the bed 48 hours after the heart attack made a huge difference in their outcome. And slowly, the both of them, they started studying what they can do for the patients too to help them. So they started allowing them to feed themselves instead of the nurses feeding them, doing their daily activities rather than having somebody else doing it for them. So going to the bathrooms on their own rather than using a bedpan. So all these small activities
So she's
help.
doing a webinar.
Uh, all these activities started helping the patients and showing they decreased their mortality rate. So they called it the patients were feeling that their health is getting better. They wrote in their articles an enhanced sense of well-being. They were starting to feel, I'm not dying anymore. I had a heart attack, but I'm not dying. I'm alive and I'm going to be able to continue my life after this. In 1954, Beckwith and colleagues said that mortality rate dropped to 7.7% from 14.4% from heart attack. And it's all due to moving the patients and allowing them to start taking care of themselves 48 hours after the heart attack. In the United States, mobility started to be more advanced in the southern part of the United States. So not just sitting the patients on the edge of the bed or sitting them in a chair where they had a specific chair called the cardiac chair. They started walking them. And Peter Gazes in Charleston, he's a physician. Charleston is in South Carolina in the United States, and Dr. Nanette Wenger in Atlanta, Georgia. She was based in Grady Hospital, which is a part of Emory Healthcare System at that time. And she started mobilizing the patient, and people were looking, are you sure you want to do that? And the way she started walking them, kept them connected to monitors. We got to remember they did this in the 1960s where they didn't have a transport monitors. We didn't have all the equipments we have today. So she allowed them to just stay connected to the monitor. She wanted to monitor their heart rate, respiratory rate, oxygen level, and made them walk around the bed. So this is how she started her mobility program. They say at that time, Grady Medical Center, Grady Memorial Hospital did not have the money to buy a cardiac chair. So she decided to do it this way. We'll keep the patient in the room, we'll keep the patient connected to the monitor, and we'll walk the patient around the bed. And where did all that started, and why more and more doctors wanted to do it? The literature mentioned that the doctors were inspired by data and information and research published by the NASA space program that said when the people are not moving much, when human beings go out to the space, there is no very little gravity there. So they waste their muscles. When they come back, they need rehab. So that's why they wanted them to move up there in the space. And the doctors here, well, that's true. When they are in the bed, our patients here are not moving. So we have reduced mobility problems, and we need to fix that to keep them healthy or to get them to become healthier. So if we look at the ABCDEF bundle, we talk a lot about it. When our patients get sick, go to the ICU, we say we have to start the ABCDEF bundle. We do it sometimes without thinking about it because it becomes part of what we do, ingrained in our culture. But what does it stand for when we talk about it? The A, it stands for prevent and assess, prevent, and manage pain. Patients experience pain, and sometimes even if they cannot talk, just because they have a breathing tube, even if they cannot tell us what they are feeling, they will have pain. So it's important to assess their pain when they are sick and in the ICU, even when they cannot talk. And that's why there is a scale called the CPOD that's used to assess the pain. B is very important. It stands for what we call SAT, SBT. What do they stand for? SAT is Spontaneous Awakening Trial. Sometimes some people call it, some clinician calls it vacation from sedation. So as the literature started coming through that we have to get the patient moving, the only way we get the patient moving, sit at the edge of the bed, sit in a cardiac chair, or walk around the bed, they have to be awake. So we need to be able to wake them up in the ICU, even if they are still on the ventilator, as long as they are safe and we are not causing any harm with that. So this is where the spontaneous awakening trial parameters came through, where there will be an assessment to see if the patients meet the criteria. That's what we call screening for SAT. Here in the United States, the nurses screen the patient for SAT, and they do SAT. Initially, all this is initiated by physicians. The physicians are going to let the nurses and the respiratory therapists know the patient is stable, and now we need to start thinking about waking them up and letting them see if they can breathe on their own to get them ready, hopefully, to move and come off the ventilator. And so the nurses will do the screening, and then they start weaning the sedation that the patient is getting. There are specific protocols that we follow. Then, once the patient passed that spontaneous awakening trial with all the steps, the role of the respiratory therapist will be to assess and screen the patient. If the patient meets the criteria to come off the ventilator, there are specific ventilator parameters that the patient has to be on to meet the criteria and be able to come off. If the patient meets those criteria, great. If not, we still have to wean the patient and get them ready at some point. So even if today the patient passed the SAT, but they did not meet the criteria for SPT, we don't stop. Sometimes we continue to wean, and the next day we'll try the spontaneous breathing trial. Spontaneous breathing trial is consistent of placing the patient on ventilator settings that allow the patient to breathe on their own with very minimal support. We utilize specific numbers based on many research that have been published. If the patient can breathe on their own, then that's a good sign. This is where the physician is going to decide, yeah, we are good to get the patient off the vent, or the patient is not ready. So if the patient is not ready and they have to stay on the ventilator, what are we going to do? Keep them in the bed? No. This is when it becomes very, very important to look at what else we can do to help them get stronger and get off the breathing machine, the ventilator. C in the ABCDF bundle is the choice of analgesia and sedation. So the patient should not be feeling pain. Again, this is controlling pain and sedation just to help them deal with having all these machines and tubes and lines connected to them. But we have to make sure we are careful how much we use. We want the patient to be comfortable, but we don't want them to be on too many medication and very high dosage, because that's gonna hurt them. D, it stands for delirium. We have to assess and prevent and manage delirium. What is delirium? Delirium is a state where patients become very confused. Sometimes they don't know where they are at. They might see things that doesn't exist. And the unfortunate thing is the delirium carries on with them even after they go home. After we get them off the ventilator, they are breathing on their own, they are doing better. They still suffer from delirium. It affects their mental status in a very negative way, and it will become a huge problem for them to carry on with their life after they have been in the ICU. That's why the ABCDF bundle became huge for everybody to understand the importance of not keeping the patients heavily sedated and helping them wake up and start moving around to reduce that delirium. E starts for early mobility, and this is where it goes hand in hand with everything we talked about. If the patient cannot come off the ventilator the minute we wake them up, it's time to start thinking, let's move them. They need to exercise their muscles, their arms, their legs, their diaphragm, how they are breathing. And this is where it takes a lot of work and coordination. The last letter is F. It's family engagement and empowerment. And what that stands for is we need the family to be there for their patient. Having family support is extremely important because it gives the patient a better sense that there is somebody there for them, in addition to all the clinical team that's there, the medical team taking care of them. And also, they help the patient too, because they encourage the patient to do things they might not be willing to do just by listening to the clinical team. And the family support is important, especially after the patient goes home, because they are going to be helping the patient to continue the healing journey until they get all better and they can do it on their own. Talking a little bit about delirium and how it started, they started recognizing the delirium problem since 1850. So Thomas Salter mentioned that in some of his papers, and they describe it as inflammation of the membrane of the brain. And Hippocrates already mentioned that the condition he described it as phrenitis, which means inflammation of the membrane of the brain. So they recognized that since in 1850. In 1944, Romano and Engel, they both ran some EEGs on patients while they were in a delirious state, and they noticed how their EEG was changing depending on their mental status. In 1959, again, Romano and Engel, they were like team working together, team of researcher. They said the delirium is caused by a metabolism problem in the membrane that surrounds the brain, which all goes back to what Thomas Salter mentioned in 1850. It was more confirmation. There were a lot of publication, diagnostic, and the statistical manual of mental disorders that addressed a lot of delirium problem. And they were published in 1952, 1968, 1980, and 2000. And they are known as DSM 1, 2, 3, and 4. In 1990, anyway, Van Dyke, Alessi, and Balkan, Siegel, and Horwitz. They were both a team of researchers that they created a scale to assess the confusion of the patients in the ICU. This is what's called now, for short, we say CAM assessment. Are we doing the CAM assessment? So confusion assessment score.
Building A, third floor, pulmonary.
Can you still see my screen?
Yes.
Okay, thank you. After the CAM method, it allowed the clinician in the ICU to go ahead and start assessing their patients for delirium and see how bad their delirium is getting. In 1996, Eli and his team started working on a spontaneous breathing trial. And that was huge in the ICUs because instead of keeping the patient paralyzed and sedated, they were able to wake them up and get them starting to breathe on their own after the SAT was done. It was a change in practice, a huge change in practice in the ICUs here in the United States. In 1999, Hopkins and his team they noticed that the patients who have ARDS, they had worse mental status decline than other patients in the ICU because those patients had a longer time needed on the ventilators and they needed more sedation, or we were sedating them a lot longer time. And it was very hard to get them to wake up. And once they woke up, it took a long time to get them out of the ICU, out of the hospital to go home. And the delirium continued with them even after they went home for a long, long time. And a long time is not months. Sometimes it might take them a couple of years before they can come out of it. So this was huge for patients who have ARDS in the ICUs. Also in 1999, Inouye and his team, they started thinking about ways to prevent the delirium. So they said it's not good enough to wait until the patient to have delirium for us to say, okay, now we have to treat the delirium. Let's work on ways to prevent the patient from getting into the delirium state. The second, it's stuck a little bit. Sorry about that. Just give me a second. Just gonna get out of this and come back just a second here.
Okay.
Just a second, Dorothy. Some reason. All right. Sorry about that. right. So thank you for your patience. Historical overview about the ABCDF bundle, how did all started. So in the year 2000, the SAT, SBT starting taking a place in a more official way in the ICUs. In 2001, the CAM, which is the confusion assessment method, was starting being utilized in the ICUs to make sure we are intervening before the patient gets into severe delirium state. In 2003, we have the Richmond agitation and sedation scale. It's used, in short, we call it RAS scoring. And this is where the patients will be assessed on specific criteria in that scale. And ideally, depending whether the physician wants them to be, should be between -1, 0, sometimes to 1. If it's way negative, like -5, -4, the patient is heavily sedated. And if it is all the way up 4 or 5, the patient is very agitated. And we don't want them to be either on either side of the spectrum. We want it to be just in the middle. In 2006, Jelinas and his team, they started the pain scale, and it stands for CPOT. We use that scale also for our ICU patients. It's called the Critical Care Pain Observation Tool, because as you remember in the ABCDF bundle, the A was assessing and preventing and treating pain. And so it's very important to make sure that the patient doesn't have pain so they can work on moving around and breathing on their own. In 2007, Bailey et al. Started early mobility for patients with respiratory failure. So not only the patients who have a heart attack, but also the patients who are having trouble breathing, had pneumonia, they were on the ventilators, so they started moving them. Early mobility started for those in 2007. In 2008, we started talking about the ABC bundle, not ABCDEF. We were not at the letter F yet, so we were still only on the ABC. So A is treating pain, B is also looking at SAT and SBT, and C is for analgesia and sedation. I'm just gonna not go on as mute because the other times froze on me. So,
Building C, first floor, integrative oncology clinic, exam room 1.
sorry about that. So in 2009, we have Riker and his team started looking at using Precedex versus midazolam. So it started doing more, using different medication where it helps the patients control a little bit the sedation, help them accept the environment that they are in rather than having them heavily sedated. And Precedex worked very well, but at the time it just came out, it was extremely expensive to purchase and use. So it was being used for very complicated specific patients. Slowly, the cost started coming down, and it's used very widely now in ICUs. Again, in 2009, there was another early mobility push for all the patients in the ICU. And now we started seeing the ABCDEE bundle. So all these letters started coming together in 2010 with Vasilevsky. And then in 2014, and we continued all the way to 2024, there have been publications about the ABCDEF bundle where they added the family engagement to that. And since then, that bundle has been complete. No other letters have been added to it since then, and we continue to use it every day in our ICUs. What are the advantages of therapeutic ambulation, moving the patients and let them walk, not only let them sit on the edge of the bed or in a chair? It's been evidence-based practice that proved that the patients get better. It prevents muscle weakness. They say 40% of ICU patients have weak muscles because they don't move. They are not using them. And the longer we keep them in the bed and not moving them around, the harder it is for them to move. That's why a lot of these patients require physical therapy, occupational therapy to also help them get back into their daily activity. Walking them will help to decrease the vent days, so they are not on the ventilators for a long time. It helps to decrease their length of stay in the ICU, so we can get them out of the ICU to the floor sooner. And it will decrease the length of stay in the hospital, so they get better sooner and they are home, hopefully back to their families and their loved ones. Decrease delirium. That's very important. The more we start moving them, that means we're not giving them a lot of medication that can cause inflammation in the membrane of the brain, and they can really continue to concentrate and be able to pay attention to their environment, and they don't have those that mental status that makes them feel they don't know where they are at or what they are doing. And then they can return to their activities of daily living. Because we know all that about mobility, we know about the importance about moving the patients. Can we just do it? Can we just go to a patient's room and say, oh, okay, we're just going to walk you today? We cannot just do that, especially when the patients are in the ICU. They are connected to the ventilator or other breathing devices, advanced respiratory support. They are connected to IVs. Sometimes they have chest tubes because they had something going on in their lungs, like pneumothorax or blood. They are connected to a monitor, and we have to keep the monitor on because that's how we know our patients are tolerating what we're doing. And then can they walk? So even if we decide, okay, this patient needs to walk, can they walk? So that's why we need physical therapy and occupational therapy to come also and assess them. Are they safe to stand up? Can they stand up? Can they walk with us? Do they need a walker? Do they need a special walker? And then for respiratory side, what are they on? And do we have the capability of moving them? The ventilators might have, for example, the batteries, but what if we are on a device, like I'm going to show you in a little bit, that doesn't have batteries, or it has a very short battery for 30 minutes or 40 minutes? How are we going to take the patients on a walk that might take an hour and a half? Is it good to take the patient out of the ICU and let them go outside the hospital? It's extremely important, and I cannot describe to you how well the patients do with that. So we need to help the patients get there, but do we have the equipment and do we have the people to do that? So that's why it takes a village to move the patient. It takes a lot of planning and coordination and understanding from all the care team members what it takes. And just to let you know, we do have also patients on ECMO, the extracorporeal membrane oxygenation. So the patients could be on advanced respiratory support. They are also on ECMO. They are on IV, chest tubes, a monitor, and we still take them on walks, and we still also take them sometimes outside as soon as they are stable enough. So to do the mobility program, it takes a lot of strong leadership. The leaders will have to advocate, whether the leaders of the respiratory care department, the physicians, the surgeons, if that involves patients who had surgery, the nursing, and physical therapy and occupational therapy, we all have to work together to say, yes, this is important. We know we have to do it. So what do we need to do? So it takes interdisciplinary collaboration. We all sit on the table together. What do we need to do to get this to happen? And then we have to plan what equipment, who's going to be present with different patients' scenarios. And then we need to have a schedule, because we have to have everybody who is needed to move the patient at that time and walk the patient ready at the same time. So we say, patient in room A, we're going to move them at 11 a.m. So that's what we do. We need to assess them if they are safe to mobilize, and that's where physical therapy and occupational therapy are extremely important, to say this patient cannot walk yet, but let's work with them in the room, get them to sit on the edge of the bed, get them to stand up and tolerate that position for so many minutes, and slowly we get them to walk. So some patients, depending on how long they were sick, how long they were on the vent and not moving around, it might take them longer than others to start moving. We talked already about having the equipment, supplies, clinician trained to do that, and then we have to have appropriate staffing. So it's everywhere. It's not a secret. So healthcare workers, whether it's everybody, there is a shortage. So trying to make sure we have enough people to do that, it's extra super important, and that's why it takes a lot of work also from the leadership all the way down. Respiratory devices that the patients can be on, if we say nasal cannula, that's very simple, or non-rebreather mask. It doesn't take a lot to move these patients. Sometimes they might use nasal cannula and non-rebreather. By the time they get admitted, they need a lot of oxygen. But at that moment, when they are needing nasal cannula and non-rebreather, what we do now, since we have the heated high-flow nasal cannula, we put them on heated high-flow nasal cannula. Some patients might be on a ventilator. When we say invasive, that means they have a breathing tube through the mouth, the nose, or through a tracheostomy tube in their neck. They might be also on non-invasive ventilation, which means they are on a device helping them to breathe with the mask on their nose or their nose and mouth. So those are, sometimes people call them BiPAP. Our patients can be also on other complicated inhaled medication, very advanced. We call them vasodilators. Those are medication that go to the pulmonary artery and relax the pulmonary artery when the patient has pulmonary artery hypertension. So we use inhaled nitric oxide. Sometimes we use inhaled ipoprostenol or Flolan. So that adds up to the equipment that we need to have and more people to be there to help us support the patient. The therapeutic ambulation not only starts on the inpatient side, but it also starts on the outpatient side. So when these patients are slowly getting sicker, or if the patients are going to have surgeries and the surgeons know that these patients are going to have a long way to heal, they start preparing them physically to be stronger before they come to the hospital and have their surgery. And here I'm talking about the surgeries that are planned surgeries. Sometimes things happen. It will be an emergency surgery, so we don't have the opportunity to help the patients get stronger before they come to the hospital and have their surgery. So the goal is to get the patient stronger when they are outside before they come in, get them in a good shape so when they have their surgery, they can get through the ICU, through the hospital stay in a much shorter time, and they can get home. And that's while maintaining their mental health and making sure, hopefully, they don't get the delirium, and or if they do, it will be very minimal because it's very hard to get the delirium and get rid of it. So before surgery, usually if we have patients who are prepping for surgery and we know ahead of time, especially the cardiothoracic surgery that are humongous and it takes a lot out of the patient, it will be, they start the preparation outside the hospital. It's a comprehensive approach. So it's treating the patient as a whole, not just you come, you have your surgery, and you go home. So it's more looking at it from the full perspective and how are we going to treat the patient. It's, as we say, the soul and the body and the mental status and the physical status and the family too. The support has to be, family support is extremely important, and the family needs to understand how important they are for their loved one so they can get better. So for respiratory side, there are pulmonary rehab program that the patients can be enrolled to even prior to surgery. That's given we have enough heads up that the patient's going to need surgery down the road. So let's start. And it will help them improve the strength of their muscles they use to breathe, to swallow. Those are very important, especially when the patient's going to be on the ventilator after surgery. Talking, swallowing, eating, and then how they can use their diaphragm to breathe. So they do all that prior to surgery, so then hopefully they can get through the surgery in a short time. And then what we run through in outpatient is how much oxygen they can give these patients while they are at home. So there is a limit depending on where the patient condition and how much the home company can provide them oxygen at home. The maximum usually around here in the United States is about 9 to 10 liters for most of the patient. So when the patients hit that 9-10 liters and they need more, this is when they come to us here to the hospital. They need to walk outside when they are still in the outpatient setting. Sometimes they encourage them to do some cycling, strengthening exercise, stretching, just to get their muscles, all their body physically fit to undergo the surgery. They recommend stair climbing for them if they can do that. And then the outpatient, if they are in a pulmonary rehab program and they need more oxygen when they are exercising, they used to be able to provide about 15 liters. Now in the presence of heated high flow, they can provide more. But this issue is the patients cannot come off that much oxygen quickly. That's what gets them to have to come to the hospital because they need all that oxygen and they cannot stay in the rehab place or the pulmonary rehab for days and days. So they end up coming to us. These are some of the body weight exercise without needing anything else. Patients are taught to do it. And sometimes they give them some videos if patients can go to the gym and they can do some weight machines to build their muscles. And so it just looks that now with they can use some weights too if they want to add to that. It depends on how good of a physical shape they are before surgery. They can use also resistance bands. So there are different things they can do with them in the outpatient rehab. Also, there are devices available in the market now, and some of them are approved for the hospital use. It's just called respiratory muscle trainers, and some of them can do inhalation muscle trainers only. Some of them do exhalation, and some of them do both. And that helps not only the patients when they are outside the hospital, but it helps them when they come into the hospital. And we have seen the use of respiratory muscle trainer helping our patients tremendously. So our biggest thing is for our patients who really, really need a lot of support are the patients who are here for cardiothoracic surgery, something going on in their heart, in their lungs, and they cannot breathe and they need a lot of oxygen. And when they get to that point, they get admitted. Now we have to help them and we have to keep them going. So they have advanced lung or heart disease. Their life expectancy usually sometimes is 1 to 2 years. They have to have a surgery, otherwise they might die within a year or two. They have the trouble breathing, their oxygen level in their blood drops 88 or less. So when they come in, there will be also a comprehensive evaluation for their status, where they are at, and then what do we need to do to get them ready for the surgery, go through surgery, and then get them home. So that's where everybody has to work together. And so these patients will move from nasal cannula. They are going to move to mask. We don't use that here. Once they are at that moment, we start using heated high flow oxygen. So we put them on that because we need to provide them with enough flow, enough oxygen to support them during their physical activity. And as we mentioned earlier, they might need vasodilators because when they have severe heart and lung problems, they might have pulmonary artery hypertension. So their pulmonary artery is very constricted. We need to help them with that. And when we saw these patients, we started seeing them more and more. It was during COVID too. And we were thinking, and we have to mobilize them. How are we going to mobilize them? Especially, they are needing heated high flow oxygen. What are we going to do? So these are the regular cannula, and this is high flow cannula, goes to 15. They don't meet the patient needs by any means. By the time they get to us, they are really out of breath. They need heated high flow oxygen. They are on about at least 50 to 60 liters per minute. Some devices can go up to 70 liters per minute. And they are on 100% oxygen with other medication going through the devices if we're giving them inhaled nitric oxide or inhaled Flolan or ibuprostanol. So to start walking them, we needed to figure out how we're going to have a battery, how long it's going to take us to get these patients to walk. So do we have battery to do that? So what we had initially, we had the Airvo 2, and the Airvo 2 didn't have an internal battery, so we couldn't use it to walk the patients. And these patients required 60 liters per minute. We had the non-invasive device, as we all know, during COVID, there were a lot of devices approved to deliver heated high flow oxygen. So we had devices that we could use at 60, 70, and 80 liters per minute, heated high flow oxygen. Our bump in the road was when we unplugged the device from the wall, the heater stopped working. So now the patient is going to be getting 60, 70, 80 liters per minute of oxygen. It's cold. We humidify, but it's really cold. The patients could not tolerate it. It was very hard for them to move around. We couldn't heat the device, and we were trying to think, what else can we do? We can walk them, if we were lucky, for 15, 20 minutes, half an hour top. And we had to put them on a mask rather than nasal cannula. The patient will feel their nose is burning. That's how cold the air and oxygen were. So we started to think we needed a battery. What battery are we going to use? And we started looking in the market, and there wasn't any battery. So we were like looking into, we have a battery here in the United States, it's the Yeti battery. Can we use the Yeti battery? Because one model is approved for CPAP. And the Yeti battery is very heavy. It almost felt like we needed a pickup truck to carry it around. And putting it and moving the patient, it was near impossible. And somehow, as we were looking into it, what else can we do? We tried to consider how much oxygen cylinders we need. So not only we needed a battery to walk the patients long distances on 60, 70, 80 liters per minute, we needed a lot of oxygen. So we had to be creative, and our team members, our respiratory therapists, created on the unit, if you want to call them refill stations with oxygen cylinders. So they kind of figure out, I have enough oxygen in the cylinders to last me for 9 minutes. I'm running on 60, 70, 80 liters per minute. So they put around the unit different carts with oxygen cylinders. So the green one had the full cylinders, and they put the empty one in the red cylinders. So we needed the refill stations. So not only we needed a battery, but we needed oxygen. So we started thinking, okay, we cannot use our non-invasive devices with heated high flow, because when we walk the patient, we cannot use the heater. So we need to use the Airvo 2. We need something, for some oxygen cylinders that we don't have to change every 8 minutes. And we need a battery that we can use. And it just sometimes God has his own ways to bring things together. So somehow our director, our respiratory care director here at Emory University Hospital, and the founder and CEO of Zopac, found each other. The story started on LinkedIn, and Strong was asking, "Do you need berries?" And that was like a godsend. Yes, we need a berry. And this is how we started working with Zopac on uh, their battery, their initial one, and we'll tell you exactly how we went through the different steps and how the collaboration between Strong, his company, and our team members of the respiratory therapists, and of course our leaders, uh, got us to have the battery that will power the Airvo, power the heaters now, and we can walk our patients safely for an hour and a half, for 90 minutes, because it takes them that long to take them around, or if we're gonna take them outside. So we started with a 60-minute battery. It did work, but we had more opportunities to get it better. So we kept on asking, we needed more time. And we always got the question from Strong, why do you need more time? Well, because I have to take the patient outside. 60 minutes is not enough. So we needed at least 90 minutes, and we needed more plugs because we have other devices that the patient needs while we are walking, and we don't have batteries for them. We need a USB cable because we have devices that use USB cables. So we were giving a whole list of wish list, if you want to call it that way. And we need this type of battery. So you will see the steps that we've gone through. And then oxygen cylinders. So per patient, we had to order approximately 50 to 80 cylinders. It depended at that time on how many patients we had walking in a day. So per one patient, we needed between about 18 to 20 cylinders in one day. So just imagine when we have 4 or 5 cylinders, how many small cylinders we needed. And this is where we had to be creative with oxygen. So all of us thinking about it, we started putting this cart together. So this cart, we designed it. So we had to order the cart. We have these H cylinders. They are big cylinders, and we did the math. Each cylinder can last the patient for an hour and a half if we are running on about 60 to 80 liters per minute. So we put the cylinders together. We mounted the Airvo 2s here. And then this is where our first battery, the 60 minutes battery from Zopac, was here in the basket. And the Airvo was connected to it. So it's heavy. It's not an easy to push cart, but it made it through, and our team members, our respiratory therapists did a great job, and they continue to do great job just to walk our patients and help them feel better. And over time, the battery evolved, and we have now with the UPS 90 Pure, it has more plugs for cords, more USB ports, and it lasts for 90 minutes. So we became a little bit more creative with the card design. We always enforce with our team the importance of having it always plugged because we need the battery to be fully charged for patient safety and to make sure we have that 90 minutes. And we always say you gotta see the letter F, that means full, before you unplug from the wall, because we always gonna have enough battery to come back. So these were the steps that we've gone through as we were working with Strong and his team. Strong Huang is the founder and CEO of Zopec Medical. We started with the T60. It drained at 60 minutes. It wasn't enough for us. We wanted more adapters. We didn't have a USB port. Then he designed the UPS 60 SIM, but it was better, but we still needed more time. That 60-minute didn't cut it for us. And then he did the UPS 90 SIM. Now we had 90 minutes. What we needed a way to mount it and protect the battery just in case if some liquid falls on it. And then we ended up with strong the UPS 90 Pure. So it has the pure sine wave power and everything else we wanted. So it was a great battery for us to use. This is a picture, and we use this also to educate our team members because we want them to know what everything is in the battery, what they need to look for to make sure the battery is good and it's going to be safe for the trip, back and forth from the patient's room and back to the patient's room. So we explain every little thing that's on it. Like here we have two plugs. Here we have USB ports, the on-off button. We always keep them on and charging. So we go through the safety check education, and we do that every day. And then, so given the size of our hospital, we are humongous. We have buildings and they are connected with bridges. And sometimes we gotta take a patient from one building to another if there is a specific test that needs to get done. And we needed to keep these patients on heated high flow oxygen. Heated high flow oxygen is not a simple oxygen like a non-rebreather. The heated high flow oxygen provides what we call in respiratory inadvertent CPAP. So we are almost giving the patient CPAP while they are on heated high flow, heated and humidified. So if I want to take the patient from room A to, let's say, a procedure in a building across the bridge, I'm going to need a battery that's going to help transport the patient. The distance between the buildings is quite long. We have the Airvo 3 that we started using for that purpose, but the battery is not enough to support a round trip. So this is why, in addition to using the Airvo 3 battery, we still needed the Zopec battery for the rounded trip. So the distance was really is really long. So we mounted the Airvo 3 on a pole with a Zopec battery. We used the UPS 90 Pure. And then because this is just for a trip, we have the e-cylinders. And when we get to our destination, we end up by changing the cylinders because we need to refill, right? But this is lighter than the other device, and it allows us to move the patients across the bridge much quicker for procedures or testing or whatever they need to do. So in other words, to sum this up, moving a patient, whether to mobilize them or keep them on their important therapy without interruption and providing them with the best care, it takes a comprehensive collaborative approach. It's a collaboration between the respiratory therapist, physical therapist, nursing, and of course the physicians are the ones who always approve anything before we do. We need to agree on the time, what time we're going to all meet and do it, create schedules for different patients. And then another thing is, as directors of respiratory departments, they always have to, here in the United States, they have to report and say why they are needing so many respiratory therapists and for what. So they had to look up for ways to prove, hey, when we transport patients across the bridge, it's taking an hour and a half. When we walk the patient, it's taking an hour and a half per patient. We needed to have orders, documentation, billing. So we had to create all that integrated in policies, integrated in our documentation system. We have to put orders in, and then we have to have documentation. And then we got it to the point where we had things all worked and situated. We still work on improving our cards so to make them look prettier at this time, but we came a long way. And I just want here to, at the end of this presentation, I want to acknowledge Emory Healthcare and Emory University Hospital for all their support, because we had great support from the system to get us doing what we are doing. And then the respiratory care department and our respiratory therapist at Emory University Hospital. Our respiratory therapists are awesome, and they made this program work. So they worked with carts they never seen before. They pushed this heavy H cylinder, and they still do, just to help our patients. And they give us ideas how we can make it better and what's working, what's not working. Also, great thank you for Fisher and Paykel. It's been a great collaboration with us and helping us throughout with things we needed from them. And a big thank you for the Africa Respiratory Care Association and for Dorothy. They are doing an awesome job, awesome work, and I couldn't believe when she approached me how they are trying to link all respiratory throughout the world, all the countries and throughout the continents, to help everybody who has respiratory problem and to spread the respiratory care profession. And I cannot tell you how important that profession is for me. I have been a respiratory therapist for about 30 some years. And every day I know how much we can help our patients. We learn something new. And the ARCA is working on spreading that. And I was so thrilled to hear that in my home country, we have also respiratory association. So I am so hopeful that we come as to a global association for respiratory care, where all the countries work together through their own association to spread our profession, because we are extra super important profession to help every patient on every continent with respiratory problem. And lastly, great thank you for Zopec Medical and Strong, who worked with us through all the Zoom meetings we had during COVID to put that barrier for us and make it work for our patients. And say thank you for everybody who joined us today.
Okay, thank you, Dr. Sue. And wait, Dr. Gbenga would have to also say something about the Zopec battery. Their hospital have also experienced this battery. Dr. Gbenga, are you there before I go to the Q&A?
Yeah, thank you very much. Thank you for the great presentation. Having the history of, mobilizing patients where, patient would just sit on the edge of the bed just to make sure that they dangle their legs, and to now fully walking the patient, because the evidence has shown that yes, patients recover faster, it decreases the length of stay. So all that stuff that you presented, thank you very much. I also want to, applaud Dorothy for all the things that she's doing with ACA, because, you mentioned that she's trying to, make sure that there's a standardized process for respiratory therapy all over the continent, which, that is a goal that we actually will achieve, sooner than later. But I also want to comment about the Zopec batteries, because we also use that for our pediatric transport as well. So, because of how long the batteries last, we are able to we do both ground and air transportation. And because of the Zopec batteries, we are able to use whatever interventions the patient needs en route to our hospital. So thank you very much for the presentation and highlighting the great battery over here, that's made by Zopec Medical, and for Dorothy and the team for putting this together. Thank you.
Thank you.
Thank you very much, Dr. Benga. Thank you once again, Dr. Sumaya. It's Q&A time, and you can post your questions at the Q&A session, and then we'll read it out. We have the technical team from Zopec Medical, also participating in this webinar. So if there is any technical question or anything about the battery you need to know, kindly feel free to ask your question. Dr. Su would also be on the other hand to address any clinical aspects that they have experience with the battery. So the floor is open. Kindly post your questions now. Thank you.
So I have a question. When in the early interventions of trying to mobilize patients, and I think that evidence has showed if it's more like a cardiac patient versus a long-term patient that's been an event. When you showed the big tanks where a lot of people had to move it around, were there any reported injuries from the clinicians? Because I can only imagine how big those H cylinders are, and trying to connect it with the F&P high flow system to be able to mobilize patients. So even though we're trying to improve the health of the patient, I hope that there was no reported in adverent, injury to the clinicians that was actually trying to help the patient. So just it's more like a question. Was there anything reported where there were the healthcare injuries because of the big bulky equipment that you guys were using to mobilize patients?
Great question. Thank you for asking. So as far as our organization, we only had one, thankfully one, and it was very minor. And this is what got us to change the design. Originally, we started with 2 carts, and we always said 2 people to change the cylinder. They are very heavy. And after we had that minor injury, and thankfully it wasn't terrible, but still it was one of our team members who got hurt. We changed how we do it. So our team members were not the ones changing the cylinders. So we had specific people designated to change the cylinders. Because respiratory therapists, some of us are taller, some of us are not as tall. The strength is different, and those cylinders are very heavy. So we had designated people who will round on these carts twice a day when we have patients who are walking, and they will change these cylinders in the morning and in the afternoon. So to prevent that from happening again. And the design of the cart, when we put the 2 other carts together, so we have a total of 4 carts for each cylinder. We worked with the company that put the carts together for us to make the process of changing the cylinders a little easier, because in the first design, we almost had to lift the cylinder a little bit to put it on the ramp. So in the second design, they made the cart a little bit lower to the ground, and they had a ramp that will allow us to get the cylinder immediately on the ramp without having to lift. And we are still working on improving the design of that cart, because it's still heavy, and moving it around is now simple. So it takes 1 RT just to make sure that cart is moving properly. That's why we need more than one respiratory therapist when we are moving these patients. But we're still working on the design.
Okay. All right. So we have questions for you, Dr. Su. It says, what are the key criteria for determining when a critically ill patient is ready to begin mobilization?
What are the clinical criteria?
Yeah, what are the key criteria to consider?
So what we look at, so depending on what device the patient is on. So if they are on heated high flow nasal cannula, as long as the physical therapy clears them for walking, or they walk them with us, even if they are on 60, 70, 80 liters with 100% oxygen, we still walk them, as long as we can maintain their oxygenation SpO2 at 92% or above. And normally these patients require a lot of stops to take a break. We use a walker that has a seat in it, so the patient can stop, sit, catch their breath, and then we keep on walking. And as we continue to do more and more walking and they get stronger, they will be able to carry on a little longer with their walk. So that's one thing we do with the heated high flow. The only time we don't walk them if their oxygen level cannot be maintained above 92% when they are walking and they are on the maximum oxygen we can give them. For the patients who are on the ventilators, they have to be on, let's say, what we say, reasonable ventilator settings. So if they are on a control mode, like assist control or SIMV, we like them to be with the respiratory rate around the 20, so they are not on a high respiratory rate, oxygen about 50% or less. PEEP could be about 8 or 10, as long as they are medically cleared by the physician. We start moving them because these patients obviously are having a hard time coming off the ventilator, and we want to move them and get them walking so we can hopefully get them off the ventilator sooner.
Okay. So a question, it's about a battery. So this goes to everyone. So how has the Zopec medical battery supported early mobility in your facility?
So with the Zopec battery, we were able to walk the patient on heated high flow oxygen. Before the Zopec battery, if we were to walk them, the patient did not get the heat and the humidity they were supposed to get. We will walk them, but it was very high flow oxygen. Sometimes they felt that their nose is burning from that. So the Zopec allowed us to utilize heat and humidity to make the walk better. So we were able to walk our patients longer distances. And the UPS 90 Pure supports also the heaters on the ventilators. Because if we were to walk the patient on the vent and we want the heater, we can use Zopec battery. Sometimes we can use something called HME, but it was extra super important for us to be able to use it for the patients who are on heated high flow nasal cannula for mobility and transport.
Okay, thank you. And then Kofi Moore, they're saying, what are the benefits and risk of early mobility for patients on advanced respiratory support, especially on nasal cannula?
So the benefit is we are going to rehab them, get them stronger, whether they are waiting for surgery. So that will get them hopefully ready to go through a surgery and recover in a shorter time. And then after surgery, we continue the walking to get them stronger, get them out of the ICU, and get them out of the hospital sooner. The risks, we have to be extra super careful that we don't compromise the patient. That's why when we walk them, we are monitoring their heart rate, their SpO2. If we need to take a break, we are going to take a break. If the patient SpO2 start hitting 88, we're going to stop. We let the patient sit, let them recover, and then we will continue when they are ready. So we have had patients in probably we didn't walk more like than probably a few steps every like the 15 minutes, and that's okay. That's how we start, baby steps until they build their strength, and we are fine with that. The risk of fall is always a big worry for us. And that's why we use a specific walker, and we work with physical therapy and occupational therapy. So these patients are usually, if you see them high risk, it's almost like a parade going down the hallway. We have multiple people, multiple clinicians taking care of them. And there will be at least one clinician responsible to make sure the patient doesn't fall. And that's why we use those special walkers with the seat. Once the patient is stronger and they can walk, we can adapt, but we have to watch for that. So,
okay, yeah,
answer.
Dr. Gwenga raised the hand.
I'm sorry.
Well, I just wanted to also add a comment that it's like an orchestra when you have to walk a intubated patient, because the patient can actually have not only with the we call them PCTs over here, patient care assistants, where they help you have physical therapy and occupational therapy and multiple RTs and then nurses based on the total number of drips that the patient has. But it takes quite a while to actually get the patient to actually walk, because if they've been in the bed for quite some time, they have to be able to build the strength and endurance, and that's where they have to initially sit at the edge of the bed, make sure that they could dangle their feet, make sure that when they stand, they could, bear their weight of their body because they've been laying down for quite some time before they actually start, walking around. So, you know, um, you know, and all this has, like you mentioned, has helped to decrease the length of stay and to help to decrease delirium as well. Because most of the time, when patients are in the ICU, it's light all the time. You don't really know if it's daytime or nighttime. That's why, we have to make sure that we let them know the days, even though they may be sedated, we still have to communicate with them to let them know that, yes, this is today's date, is the time, and this is the plan for you today. So thank you for those comments.
Thank you. Okay, so another question says, how can multidisciplinary team effectively collaborate to implement a mobility protocol in a resource-limited settings? So this goes to like developing countries,
Okay.
Africa. Yeah.
It is not easy and it is not simple. I wish if I can say it can be done. I wish if we can walk every patient in the ICU who meet the criteria for mobility every day. We cannot. But what we do the best we can, and we put a schedule. Can the patient walk every day? Those patients that they are on ECMO and they are on a vent and they have about 20 drips going on and they need about 10 people to help them walk. Sometimes we might be able to walk them once a day. Sometimes probably we do five times a week rather than 7 times a week. The other patients who are less critical and they are on less support, we can walk them. Does it take a sacrifice? Yes, from the RT. Sometimes they are running day and night. Same thing with nursing, same thing with OT and PT. So we put all schedules together to see how we can make it happen. With limited resources, you might not be able to walk every patient every day. That's not something easy to accomplish. But can we move them at least 3 times a week? So these are like some of the things we look at. So can we move that patient 3 times a week? Even if we cannot walk them for an hour and a half, can we walk them for just 30 minutes? And exactly like Dr. Bengido mentioned, sometimes getting them from the bed to the door is half an hour. And that's why we needed that 90-minute battery, because for the first 30 minutes, it takes us that long to get the patient to the door. So you do the best you can with what you have.
Yeah. Okay. And a question from Soba. It says they have a lot of patients who that have like stroke, TBI, and all that. So patients whose mobility is a bit of a challenge. How do we mobilize early for these patients?
Those patients, it depends how bad the stroke is. If it just affected them and they cannot walk, this is where PT and OT work with them. So they take a lot of rehabilitation, and those are the ones that we cannot take them out of the hallway walking. But let's say we need to take them out because mental health is super important. So if they are on high respiratory support, we will be involved to take them just outside to see something different and help them with their mental health. But we will not walk them. It's going to be a while for them to heal. With PT and OT working with them over time. Sometimes they leave our hospital and they go to specialty hospitals for rehabilitation before they can walk.
Okay. So from Mustafa Kewa, this is coming from Lebanon. He said, hello, all the way from Lebanon Association for Respiratory Care. They said they are very honored and proud to achieve this milestone. And then they also congratulate you for the opportunity to present on this webinar. So from Lebanon, they are giving their support to you.
Thank you. Thank you. I am very thrilled. I was very thrilled to see we have an association for respiratory care. So it's great to have you also join us. Thank you.
Yes, okay, and also from Chad in Africa. It says, Dr. Sumaya, thanks a lot for sharing this and then for the knowledge and experience you have given us. My question is, what is the one thing you would want every respiratory therapist in the ICU to know about moving patients safely?
The one thing is, I would say it's two parts. They have to be safe so they don't get hurt, know exactly how to move the patient safely, and actually know once they have the order from the physician, what do they need to have and do to be safe for the patient. So safety is for the patient, and safety is also for the respiratory therapist and all the clinicians involved.
Okay, so also from Mustafa again. So how about patients that are in isolation? How do you handle mobility?
Believe it or not, we walk them. So we have our infectious disease that determines what the patient need to wear and what we need to wear when we take them outside in the hallway. So there is, depending on what type of isolation they are in, we follow that. And sometimes the patient himself or herself, they have to wear a gown. We are wearing gowns too, and of course the gloves and everything that comes with that. And we are very careful with the surfaces to keep the surfaces clean and wiped down. But we still walk them. That doesn't mean we keep them contained in the room.
Okay. All right. So there's this one question. I think this is a technical question. Katie is asking, how long does the battery take when you're, for example, transporting your patient to another place? Okay, so what the person is trying to ask is, how long does the battery take to walk this patient or to move the patient about? So, Dr. Su, you can answer, and also I leave this for the ZOPEC team to also answer.
So for us, it's a 90 minutes, and we like the UPS 90 Pure. It has alarms, so it starts alarming about like when it starts getting low to tell us you gotta get back. So that's a warning for us. But because we use it, we know it's only 90 minutes. So we always make sure as if we are walking the patient, that we have to work our way back to the room at like 45 minutes. Sometimes we just like about 40 minutes and we start the return. Moving the patients, the most it will take probably about 35-40 minutes. So we have enough time in the Barry, 90 minutes, to do a round trip with it. And the way a UPS Pure 90 is made on the Airvo 3s, if something goes, if the battery depletes, it switches to the Airvo 3 battery, which will give us another half an hour, 40 minutes. That's why we love the design of it. So it works in many different ways. I do really want to say thank you for everybody who attended. I do really appreciate the support from everybody, ARCA, ZOPEC. Very thrilled to see people from different countries and also especially from my home country, Lebanon. All what I hope is like our respiratory profession continue to grow, and if we can have like a whole world association for respiratory care where all the different association come together just to help us keep on pushing our profession up, because we are extra super important profession for everybody, every patient on every continent.
Thank you very much once again. And then also to our participants, Africa Respiratory Care Association has come to stay, and we are ensuring that respiratory therapy reaches every part of Africa and to the world at large. Now, there are more countries that are joining and international countries that are joining. So far, we have Lebanon joining the Africa Respiratory Care. We have Guyana, we have Jamaica, we have Pakistan also joining, and more countries are joining. This is because respiratory therapy, there is a need for respiratory therapy in every country. And that is what the Africa Respiratory Care Association hopes to achieve. Now, Dr. Gbenga would want to say a bit, and then we can showcase our Q&A. So we have over here a survey that is titled Validation of the Respiratory Therapy Profession for Africa Healthcare System. Now, this survey, I entreat all of you to scan it. We have French version and the English version. If you are a respiratory therapist, you don't have to scan this because this is for a non-respiratory therapist that is participating in this webinar to scan and fill out a survey to know your thought and your mind towards respiratory therapists in your country. We want to ensure that your country actually needs these professionals. So kindly fill out this survey and we will be happy you did. This is in a way to support the Africa Respiratory Care Association. And if you are an institution or a company or an individual or organization that would like to promote respiratory therapy across the continent of Africa and the world at large, kindly support the Africa Respiratory Care Association. When you go on our website, we have support or donate. You can click on it and support and then donate in any kind. You can donate financially, and which would also help boost our initiative and whatever we are doing to enhance respiratory therapy across the continent of Africa. So this is the sponsorship and donation form. So you can sponsor at sponsorship@africaresp.org or donate at africaresp.org. And if you have any questions or ideas, or anyway, maybe any of the webinars that have been presented or this particular webinar, and you have any questions or follow-ups, you can contact us at info@africaresp.org and we would help you. And to join the Africa Respiratory Care Association, if you haven't, kindly log on to www.africaresp.org and join. So we'll be glad you joined. You don't have to be a respiratory therapist to join the African Respiratory Care Association. We need everyone with every background to join. This is a way to advocate and to promote and to support respiratory therapists across the continent of Africa and the world at large. Thank you very much for making time to participate in this webinar session. I'm sure you have been enlightened on the ZOPEC battery and patient mobility. And if you want certificate for participation, kindly contact the Africa Respiratory Care Association through the info@africaresp.org. That way we can follow some steps with you for you to achieve or attain your certificates for participation. So on that note, this is where we close the curtain for today's webinar.